Morning, ladies and gentlemen. Welcome to this session. My name is James Mpunga. I'm co-chair to this session. My colleague is...
Hi, my name is Catherine Horton. I'm from the London School of Hygiene and Tropical Medicine.
Thank you very much. This session will discuss about the priorities in identifying missing cases. I think all of us are aware that the national TB control programs continue to miss a lot of TB patients due to a host of reasons, be it a cost on the health systems, on our patients themselves. We are talking now about catastrophic costs, issues of access to care in our countries, issues of reporting challenges, whether it's data recording and reporting, interventions probably that we need also to think again. Talking about active case finding, passive case finding, and seeing the difference in terms of the effectiveness of each method. So the presentations that we have today, I think, will take us through some of the challenges that we meet in the health sector as we are trying to make sure that we find these missing cases. Colleagues, I think you know that we have carried out a number of prevalence surveys in most of the countries, and we continue to see a lot of missing cases. The notifications, compared to the prevalent cases, they're usually very far apart. So I welcome you to this session. We are going to hear from 9 presenters, and we hope by the end of the 1.5 hours, we should be able to address most of the issues that we have. Can I turn over now to Catherine to call the first speaker?
Certainly. I will also add a brief administrative note. Because we have so many speakers in this session, we would really ask that our speakers try to stick to time, keep their talks to about 8 minutes so we have time for a question or two at the end. We will give you a signal at 7 minutes and again at 8 minutes so you know how you're doing on time. I'd like to invite Fintabil Getnet, Mei Kwan, to shift gears a little bit away from contact investigation and discuss TB among immigrant workers from highly endemic countries following pre-entry screening in Taiwan.
Distinguished guests, dear colleagues, thank you for this opportunity. Offer this opportunity. My talk today is about the screening program of immigrant workers in Taiwan. Excuse me. Next one is one. In industry countries, tuberculosis cases are concentrated among immigrants and driven by reactivation of latent TB. To respond to this risk, many countries screen immigrants from active TB, and some countries also screen for latent TB. Taiwan immigrant TB control policy aims primarily to screening active TB cases through chest radiograph for prevention. Taiwan is an intermediate tuberculosis country with approximately 50 per 100,000 people's TB cases, and most of the TB cases was aged over 15, and the average annual immigrant worker population is about 400,000. In Taiwan, the admission criteria for 3 years residency of new immigrant worker from highly endemic country is an overseas pre-entry normal chest rate approval. Then all immigrant workers are mandatorily followed by 4 rounds of screening. Those TB positive cases were not allowed to enter or remain in Taiwan during 2011 to 2030. However, the policy has changed. Only the multiple drug-resistant TB case will repatriated. So this study was aimed to analyze TB burden among immigrant workers under such policy and evaluate the screening effectiveness. Data was obtained from the National TB Registry database, which was a web-based nationwide notification system, and to stratify the TB case finding by active post-entry screening or passive surveillance. The number of insurance was linked with the database of National Immigrant Worker Physician Examination database to obtain the screening data detail. To estimate the TB burden, we used the cumulative instance, which was include those cases detect within post-entry 3 days, which might be the prevalence cases. Results. So the immigrant worker was most aged between 20 to 40 years old. The list, and with the instance about 100 per 100,000, which was 2 to 4 for the higher TB instance than the then the corresponding age is the domestic Taiwanese. In parallel, the fluctuation of TB incidence among immigrant workers of each nationality in Taiwan was significantly positive associated with the WHO estimate in their original countries. This figure demonstrates the 9 chart demonstrated the fluctuation of TB incidence. You can see there's no significant difference between the policy of the repatriated TB cases before and after 2014, and you can see the population and the incidence with an increased trend in the Indonesia, the slight decline in Vietnam. This was the clinical diagnosis correct outcome. Most cases was sputum smear negative pulmonary TB case encompassing 74%. This demonstrates the clinical characteristics of passive identified cases with a slight higher odds ratio of smear positive cases. About in terms of the effectiveness of active screening, this figure can show you each year's fluctuation of the screening year, and we can see that only in 2040, in the 3rd round and the 4th round, we got we hear the TB cases was larger than the cutoff value, and the positive predicted value is about 52. So under this, is it time? My conclusion is the current mandatory post-entry screening programs for TB could actively finding 41% of TB cases at early stage and reducing potential transmission. The entry worker with normal chest rate from highly endemic countries would sustain a high TB incidence, which might be due to reactivation of late TB. So consider the so we might recommend to incorporating LTV screening, the ITP, for immigrant worker from TB highly endemic region might be next step. Thank you for your attention.
Thank you very much.